as well as this equilism space beneath the retina. It's probably liquefactive necrosis that is already pre-existing. And this is the case. This particular case, I had a little bit of difficulty in achieving a good bleb. I had to use two sites at least to achieve a good bleb. And so probably actually I'll come back to the reason later on. Yeah. Probably, I presumed it was because this patient was pretty young, that it was not so easy to detach the retina and create more space for the injection of the drug, the healthy RPE. So the drug, good bleb is formed. And in this particular patient, because I found it was very difficult to inject the drug and little space, I thought injecting air will give it, will increase the size of the detachment and help it in more displacement of the hemorrhage post injection. So at the end of surgery, I injected subretinal air through the same site where the drug was injected. Yeah, this patient also recovered very good vision, but had a foveal thinning, and we could subsequently see that expected this kind of return based on the preoperative OCT. Now, this is another technique that has been described where the authors have suggested that Toshio et al. That localized removal of internal limiting membrane at the injection site helps in the ease of injection of the drug, whatever that you're using. It's a very interesting finding that after removing of the localized internal limiting membrane, they said that just placing the tip of the cannula on the retinal nerve fiber layer and injecting is enough to create a bleb rather than penetrate the full thickness of retina. I personally have not done it, but I think it's a very good idea because it prevents any damage to the underlying RPE or choroid. And this is more so important when you're giving subretinal gene therapy, where you do not want to cause any trauma to the underlying RPE. And they found that the ease with which injection is without removing ILM, if you need 12 psi. After removing the ILM and placing the polyamide tip on the retinal nerve fiber layer, you can do it at 6 psi. This is something that you all could try, and definitely I'll be trying subsequently. The third case of a post-traumatic submacular hemorrhage with a macular hole as well. There is as well. Yeah, then apart from submacular hemorrhage, there is exudative fluid as well in the space, and the OCT shows a macular hole. And this, while injecting the TPA, you can see that some amount of hemorrhage is coming from the pre-existing macular hole. This was a bit expected, but otherwise, if you're not diagnosed a macular hole preoperatively, you should be wary of this kind of trickle from the macula, because then you have created one. So after injecting the drug, the fluid what is drained, and internal limiting inverted ILM peeling was done to close the macular hole. And a little bit more of drug was injected subsequently. And these flaps were put in place on the hole. This particular patient did very well. Apart from that, there is underlying choroidal rupture in this boy, and is recovered vision of 618 in this patient. And this is the other techniques of closing a macular hole. Hydraulic centripetal macular displacement technique typically it is used spinning up to arcades, and then doing a bit massaging of the edge of the macular hole so that they slightly oppose. Yeah. And finally, this is a case of a proliferative diabetic retinopathy, the subhyaloid hemorrhage during the laser proliferative diabetic retinopathy. During the follow-up, this particular lady presented with a fresh submacular hemorrhage of unknown origin. We tried OCT angio, we could not find any reason. This patient had a sudden drop in vision as well, from 618 to 360. So this patient surgery was offered, and intraoperatively found that the extent of submacular hemorrhage slightly increased in the 2 days the between the this is a submacular hemorrhage that you can see. This particular patient had intraoperative cataract formation, and subsequently the surgery had to be and it was not there was a poor visibility, so silicone oil was injected, and after injecting the silicone oil, the TPA was injected through that cataract. You could do that. This was a visibility in spite of silicone oil injection. But somehow I could achieve a bleb towards the end of surgery, and this patient too did really well, and you can see that there is significant displacement of submacular hemorrhage right on day one, and very good. And this planned foveal detachment technique is also being used for resolution of diabetic macular edema that is resistant to anti-VEGF or Ozurdex. Instead of plain vitrectomy and ILM peeling, we would also give a subretinal BSS injection in the macular area that will help decrease the edema even faster. That's what these authors say. Rapid resolution of DME and degree of vision is better than conventional with ILM peeling, and it adds additively or synergistically to conventional macular edema. The theorizing is that by reducing oncotic pressure and viscosity of subretinal fluid, as well as improving the microenvironment around the RPE. So these authors use the same technique of removing the ILM peeling and placing the polyamide tip on the nerve fiber layer and not penetrating the full thickness of retina. This is the last device that has been coming into play. I think it will be a game changer. Nano-vitreoretinal subretinal gateway device to displace the submacular hemorrhage. Basically, it involves a handpiece with a slide action mechanism and a 30-gauge needle at the tip, with N-sheath subretinal cannula, probably 41 gauge. And this technique is to be done without vitrectomy. There is a chandelier light that has been in place. This is a needle with a subretinal cannula, closed range, and testing the drug outside. And this needle, you go through the pars plana area, and once inside the vitreous cavity, the sliding mechanism, you take out the 41 gauge needle and give a drug subretinally. This technique is very important. I think useful in case of where cause of submacular hemorrhage is a CNVM, where subsequently if you can manage to do without a vitrectomy, you can continue to give anti-VEGF injections post-operatively. I think they act better rather than doing a complete vitrectomy and subsequently you find that subretinal injections, the intravitreal anti-VEGF injections are not working so well because we removed the entire drug. Thank you.
Thank you, Dr. Raja sir. Sir, we'll ask Dr. Shubhendu sir to share a screen, and we'll take up the Q&A after Dr. Shubhendu's, and we have one more case presentation by Dr. Ashish. So if we can have this thing, then we'll take the Q&A after that. Thank you so
Shall
much.
I stop share? Shall I
Yes.
stop sharing? Yeah,
Yes.
yeah, yeah.
Dr. Shubhendu sir, if you can please share your screen, please.
Yes. Can you see my screen?
Yeah, Shubhendu, you can.
So it was very nice and nice presentation, but ready in details. And I also think that you can apply subretinal injection in multiple situations. Even few days back, I used in Coats disease to displace the submacular exudate, as well as I used in cases with FEVR with falciform fold also. In such cases, I have used subretinal injection technique. Also in diabetic maculopathy, subfoveal exudate removal and along with air injection subretinal. Basically, all these things are not proved their efficacy completely. There's scattered evidence of, uh, but a lot of things you can explore with this subretinal injection and air. But this kind of bleb formation SRF will be dissolved within few days. I think not even weeks. One maximum 7 to 10 days. This subretinal fluid will be dissolved. Now coming to the another situation, this autologous retinal graft. I think everybody of us nowadays you should know. Basically, I faced in some situation where I can share my video, very limited situation experience till now. But autologous retinal graft, at least a retina surgeon should know, and you should apply accordingly in such situation where no other techniques will be beneficial. I will share my video. Like autologous universal retinal flap surgery, it was first described by
Dr. Shubhendu sir, sorry to interrupt you. Sir, I think we had discussed about having cases related to subretinal injections.
Okay.
So if we can have that presentation and then we'll...
First. Okay, sure.
Right. And then, sir, later on, once we have done the Q&A
okay.
for this topic...
That's fine. So
right.
Submacular hemorrhage, this kind of algorithm I used to follow. There is small size, it is less than 4 diameter, and it is recent onset 2 weeks duration. So anti-VEGF or pneumodiscipline suffices. If it is medium sized, more than 4 diameter, but not extending beyond the temporal vascular arcade, and the duration is 2 to 4 weeks. So this kind of situation, cocktail of subretinal TPA, anti-VEGF, and air injection, I always prefer. And if it is massive, more than 60 diameter, and the temporal margin is extending beyond the major vascular arcade. So in this situation, subretinal TPA, retinotomy followed by subretinal blood removal, or subretinal TPA or temporal followed by temporal GRT, creating GRT and bulk image. Or if it is very long-standing or old hemorrhage, in this situation, you have to remove the subretinal scar. So in this situation, I am removing the blood along with neovascular membrane, along with RP choroid, full thickness RP choroid autologous graft transplantation. So coming to a scenario where the size of the hemorrhage is medium size, more than 3 to 4 diameter, but not extending beyond the temporal vascular arcade, and the duration is 2 to 4 weeks. It's the ideal situation of subretinal TPA. So if it is massive, thick subfoveal hemorrhage and extend the upper limit of the hemorrhage, it is just above the fovea. So it is the ideal, you have to displace the blood from the macular area. So our TPA dose, that in many studies result actually showed the result of 12.5 milligram microgram point in the 0.1 ml to 50 microgram in the 0.4 ml. So we are using acid actylized. I don't have any final chemicals because it is available quite easily in market. So 20 milligram in 20 ml, you have to dissolve the powder in 20 ml. It gives a solution. Take maximum 0.5 ml. That is 50 microgram in 0.05 ml. So now this is the situation where both you can see the both subneurosensory retinal RP hemorrhage and sub RP and subneurosensory retinal hemorrhage is there. So you can see the sub RP part of the blood is there, and along with that You can see the subneedle-sensitive retinal detachment also, subneedle-sensitive blood is also there. So in this combination, basically, if you are planning for the subretinal TPA, it is subneedle-sensitive retinal TPA you have to give. Basically, we are generally avoiding sub-RP TPA injection because of its systemic absorption. Like in this case where I'm doing vitrectomy, injecting the triamcinolone and inducing the PVD, then directly injecting the neurosynthetic retina here, subneurosynthetic retina TPA, then waiting for some time, and then again directly in this case I have injected in sub-RP TPA. I waited for some time, at least 15 minutes, 10 to 15 minutes, then injected subretinal anti-VEGF and AR injection, and then ask the patient to maintain the propped up position for at least 12 hours, followed by the the prone position to sweep the residual blood from the macular area. So this is the this kind of regimen I followed, and ultimately patient gained decent vision with complete resolution RP, and you can see the sub RP and sub retinal fluid. Just a minute. Okay. Like I also another, this is a cocktail of subretinal TP and anti-VEGF and AR injection. That is the logistic. When I'm giving this thing subretinal TP, you can see that there is light plus the color of the light blood would be like this. And when you inject the subretinal AR, this AR, and ask the patient to maintain the propped up position, the AR will displace the light blood inferiorly, so that the patient's fovea will be relatively blood free, and for if he, and after 12 hours, if he maintains the prone positioning, then residual blood will be displaced from the foveal area. So submacular and sub-ILM hemorrhage post-macular aneurysms is another situation where you can see both submacular and sub-ILM hemorrhage. And here you can see I am planning for subretinal TPA injection here. Not anti-VEGF, because it is actually sub-ILM hemorrhage. It is from the macular aneurysm. So I am removing the sub-ILM hemorrhage, taking the 40 gauge metallic needle, injecting the subretinal TPA here, and waiting for some time, then you do the fluid exchange. And in this case, after doing the surgery and removing the sub-ILM and sub-RP sub-neurosynthetic blood, you can see the blood, actually you can see the whole reflex of neurosynthetic elevation, and the whole thing has gone. Patient gained 6/12 vision after 3 weeks, and after 6 weeks, I have done the gentle laser over the mechanism, site of mechanism. You can see the site of mechanism here. So these are the cases for the subretinal injection. Should I continue with the RP and autologous retinal graft, or
we'll take it after the Q&A of this?
Okay, sure.
Thank you so much, sir. We'll have Dr. Ashish Markan to kindly share his screen. Dr. Ashish Markan is doing his MCHH PG at Chandigarh, and he has done his SRship at AIMS in vitro retina. Dr. Ashish, if you can kindly share your screen and present your case, please. Thank you.
So a very good evening to all. So in today's discussion, I'll be presenting a case of a 53-year-old female who presented to us with sudden onset diminution of vision in the left eye from last 2 days. So she was a known hypertensive from last 12 years and had a grade 4 nuclear sclerosis. Patient was on treatment for prolapsed intravitreal disc and was unable to maintain any prone position. Fundus examination revealed the presence of a ruptured retinal artery macroaneurysm along the supratemporal arcade with presence of a thick subretinal bleed. So we decided to go ahead with a sequential surgery. So initially patient was planned for a cataract surgery. So after a successful placement of PCIOL in the bag, so 4 days later we planned for a 25G partial vitrectomy with subretinal injection of TPA with gas. So I'll be just showing the surgical video. So here the 3 standard Parsnip ports were made. So here we can see that there is subretinal bleed along with the presence of this ruptured retinal artery macroaneurysm. So once the core vitrectomy was done and tricot was injected to look for the PVD status. So the PVD was already present. So rest of the vitrectomy was completed in the mid-peripheral as well as in the peripheral areas. So this was the site of the ruptured retinal artery macroaneurysm in the supratemporal arcade. So we took this 39 gauge polytip cannula, which is manufactured by Med1. So this is stiff enough to penetrate the retina. So once the retina was penetrated in the superior part, so a bleb of 0.3 ml TPA with 0.3 ml of air was injected into the subretinal space. So we have to be very sure that we make a sufficiently large bleb so that the bleed is displaced from the fovea. So once the bleb was created, so there was some amount of air which came out through the bleb and was behind the IOL, so that was removed. So finally, once we're very sure that a sufficiently large amount of bleb is created, then a partial fluid air exchange is performed. So it is not necessary to do a full fluid air exchange. So just a partial fluid air exchange followed by a tamponade with 20% SF6, and post-operatively the patient was given a propped up position. So this is the outcome at 3 days. So the bleed had displaced inferiorly at third day. The vision of the patient improved to 1/60, and at 3 months the vision was improved to 618, and there was complete resolution of the submacular bleed. Thank you.
Thank you, Dr. Ashish, to sum it up so nicely. So, coming up with the Q&A for this, we asked to all the panelists which we have here. We'll start with Dr. Raja, sir. I would want to ask that which type of injections do you actually prefer, whether it is automated ones or the manual injections? And if you're doing the manual injections, what are the problems do you face, or what are the challenges when you do? So if you can have that video where we actually, for the manual injections, if that could be discussed and shared, sir.
See, most of the time, you might say it's only the first time when I injected that I did it myself. Subsequently, it's all using the viscous fluid injection module that Constellation offers. Now, the only difference is that either you place the drug in a, I think it's okay to place, so because TBA once reconstituted, there's little or no, they cannot be used for any other time. So it's been used for one patient. So drug, you can keep the same drug in the 10 ml syringe, BD syringe, and 1 ml of drug, and then through the foot pedal you activate, and then you give the injection. The other way that you can do with automated again is that there are microdose injector that I have that Med1 supplies. That's another way. There's a third technique that's also I didn't show the video where you can cut the 1 ml syringe and place it inside a 10cc syringe and again do the drug. But most of the time, one of these two techniques work. I mean, it's always advisable that you, rather than injecting manually with your hand, you use the viscous fluid injection module that the vitrectomy system offers. Yeah.
Thank you so much, sir. So is there, I can ask Dr. Shubhendu sir also about this. Is there any specific site for injection which you actually choose when you're actually injecting subretinally? Or is it
basically it depends on depends on the shape of the hematoma, how much part of the fovea it is involved. If it is involved in the fovea and is relatively the superior part of the macula and retina is almost free, so you have to inject it inferiorly. And especially if you want to avoid the formation of macula hole, you have to go beyond the intertemporal arcade, vascular arcade. If you go beyond the temporal vascular arcade, it is the blob like you are injecting some fluid. Again, I am injecting also anti-VEGF as well as here, and increasing the subretinal volume. So increase the subretinal pressure. You are injecting a lot of fluid. It is going subretinal space, and if there is some kind of scar is there and a lot of adhesion between the scar and innocence retina, that will cause localized at a loculated place, space, so that fluid will not go beyond your macular area, especially inferiorly on other part of the blood. So that may increase the subretinal pressure and can create arterionic macrohole formation. So in this situation, you have to be very careful when injecting the blood. And sometimes, many times, preferably I basically, my assistant is very, like, his hands are very stable, so I am preferring manual technique. Very rarely I am utilizing the VFC syringe. So in this situation, you have to be very careful. You don't have to, if you are doing the automated system, don't have to place the full press on the paddle to inject the subretinal TPA.
Yeah,
So,
there's one I would like just to add that I think with this 41 gauge needle, the formation of scotoma is never a big concern. So, and also that depending on the size of the hemorrhage, if it is too huge, you may need to inject it multiple places, at 3 to 4 places. So it's not always, so you need to, without hesitation, I think you can create 2-3 blebs in a large submacular hemorrhage if you have, if you have. And one more thing which I've seen of late and recently in the Uretina video is that to prevent the formation of any macular hole, if this localized is very localized, you're concerned that you may create a macular hole while trying to inject TPA. They've described it taking where you put a PFCL on the submacular hemorrhage, and then you inject subretinal TPA, so that you don't have any bursting of formation of a macula, the exit of the blood through the macula hole. So injecting a PFCL bubble on the macula, and through that you inject a subretinal TPA, is another option that you can think of.
So in the videos which we had seen, we could see that the injection was injected. Along with the injection, we could see the expanding, which we are seeing. Whether do you actually do it in a large single sort of a bleb, or do you push it for multiple blebs and then let it coalesce? Which one do you prefer in either of the two? And if we can.
It's always.
Yes,
it's good to inject at multiple places and then collapse rather than all at one, at least 2 places. The hemorrhage is huge. And that's
basically you have to inject what Dr. Reddy was telling. You have to inject at least more than 1 places. That is 2 places you have to inject. You can inject into 4 places, but mind the total volume of the injection, that total dose, that it should prevent that you can prevent the systemic further toxicity of the TPA. That is then the volume, what is the dose you are admitting. You can inject. That is it's not a big thing. But especially your foveal part should be free of blood. That is the main thing. So if the rest of the part, blood will dissolve in the course of time. It will dissolve. You can see the blood is gradually, after 6 to 7 weeks or 8 weeks, you can see that almost the whole of the blood is dissolved.
Dr. Subhendu, just you said that in the video that you showed, you injected again to into the PED as well.
Yes, generally sub PED, but sub RP injection is not recommended because of the systemic absorption of the TPA. But in that case, I felt that maybe the sub it worked. It worked so nicely without any toxicity. But it was like I was a little bit hesitant because one of my initial videos, like I was thinking that maybe I can inject the sub PED, that will be beneficial, and ultimately the whole PED has totally resolved. It is totally flattened, and that again still it works. It works, but usually it is not recommended.
Yeah.
Dr. Rajas, we saw in your videos that initially in the first video which you showed, there was some assistant, you were saying that it was difficult to penetrate into the subretinal space. So do you actually do ILM peel in all sort of cases? And during the injection? And when do you do it? Whether it's after the injection or before the injection?
Actually, regarding ILM peel, I've read about it, and what I've read has also been confirmed. It has been cited by other surgeons as well, that definitely peeling the ILM peeling decreases the resistance of injection by half. And more importantly, other most important thing which I found is that you need not sometimes penetrate the full thickness of the retina. You just need to place the polyamide tip on the nerve fiber layer. That jet itself is good enough to give you a bleb. This is something not have been tried, but I'm very keen to probably do it in my next case. the difficulty in the injection, which I have not explained in the video, that's because probably yeah, in the creation of the bleb, initially I thought it was a pretty young patient, probably because previously all the other patients were AMD patients. There were little loose adhesions or something. This particular patient, I had a difficulty, but I think that's mostly due to physics involved. I think the assistant gave me the entire drug loaded in a 10 cc syringe, almost 8 cc. I was trying to inject through a larger syringe. Probably that's the reason why I needed a apply. It was probably difficult to inject as well. But otherwise, I think it's good 10 cc syringe. If you take a 1 ml of drug and then inject it to that, it should be very difficult. Yeah.
Thank you so much, sir. Mr. Dr. Ribhu, so if you can please mute your mic, please. It's causing a lot of disturbance. Dr. Ribhu Soni, please, if you can mute. So coming on to the complications, I think one of the surgeries in which you actually showed that there was kind of a ooze coming out from the foveal space.
Yeah.
So, what are the complications you have actually encountered when you're giving an injection, and on a long-term basis, what sort of outcomes do you actually predict in these sort of cases?
The ooze, that video that I showed, that patient actually had a full thickness macular hole, so it was expected that through the hole it will ooze, and then of course we close the hole with LMPP. But otherwise, till now I've not had any complications with the injection procedure as such. Even like in terms of macular bursting or anything, you can try to avoid that by putting a PFCL bubble, and that's what the results. I have not had any complications so far. They've been very encouraging. I mean, you can only the other tip to increase the penetration is if you want to is to cut the bevel of that polyamide tip, make it beveled, so that may increase make it more easier to give it subretinally. Yeah.
You can make it beveled, but if the thickness height is not that high, so the part of the beveled end may enter inside the subretinal part, may be inside the vitreous cavity. So whole of your drug may not penetrate into the subretinal space.
Yeah. But actually, I've not tried. This is only something which I've read in the literature. I particularly have never cut the tip and given the injection.
Dr. Reddy, I faced few complications. Like in one case, on-table macular hole formation was there, and I just drained the fluid from the macular hole, it closed. And 2 cases, I faced post-operative macular formation, although the pre-operative, like in your case, the existing macular hole was not there. It was might be due to the subretinal injection. One case, I faced macular hole with RD. So in those cases, like in one case, I did the inverted INM flap. So that this thing has been totally closed. I have the video also, and it was nicely doing okay. And the macular hole with RD also, like in my sub-PFCL ILM pinning and inverting the flap over the macular hole, I did it. So these 3 or 4 cases, I faced one intraoperative macular hole, 2 cases post-operative macular hole, 1 case macular hole with detachment. So I did more than 50 cases. So out of 50 cases, more than 50 cases, I faced 3 or 4 complications till now.
Thank you, sir.
And 1 case recurrent subretinal hemorrhage that ultimately I had to do the RP, creating the GRT, temporal GRT, and I had to do the RP choroid graft transplantation along with blood results.
Yeah, the other important is I was talking about this video from Uretina. You can place a PFCL bubble and inject the drug, not necessarily where the subretinal hemorrhage is, slightly adjacent to it, and let that bleb coalesce and get mixed with the drug. That's also an useful technique.
I think I'll just add a small comment. This is especially preferable when you are not using automated VFI. If you are injecting manually yourself, which is my preferred technique. I tend to inject myself manually, but create 2-3 blebs, and first you fire it in the vitreous cavity to get the feeling that how much force you will require. Sometimes you are struggling, you are thinking that needle is not penetrating retina. It's actually resistance of the syringe which might be troubling. So if you are going with automated VFI, actually refilling and creating that system, and then silicone oil tubings are also reused. So you tend to use more sterile kind of injecting mechanism. Better to inject manually also. But yes, automated VFI is also good if you can modify it. Your scrub nurse is expert in doing that. Right. But nice comments, sir. Thank you.
Thank you, Dipender sir. I think there were a lot of learning curves and points which we had taken. Just because of shortage of time, we'll ask Dr. Devakant if we have any questions from the audience, and then we'll move on to the next topic.
Yeah, there are a couple of questions in the chat box. Maybe we can deal with them quickly. So one is from Dr. Deepak Bhojwani regarding TPA toxicity and how does it look clinically?
If anyone from the panel can answer this, please.
No, I didn't face any kind of systemic toxicity of the TPA and clinical presentation of TPA toxicity systemic. I did more than 50 cases, but still I didn't find any toxicity of TPA, any hemorrhagic.
I think in intravitreal doses, anything above 50 micrograms per
yes,
ml
I used to follow subretinal.
But now the amount, normally we use 25 and the total amount which we are giving is not that much. And another thing is a lot of TPA binds to the clotting factors. So free TPA is not available for toxicity. But this is something which we still have to be careful. I have seen few surgeons actually after injecting TPA waiting for 20 minutes and they then try to aspirate also. Their main purpose was to remove the blood, but sometimes I ask them that are you doing it to remove TPA also, which can be toxic. So nobody thought actually that TPA is toxic, but we don't have a clear answer. Subretinal TPA, how much big bleb is non-toxic, because total cumulative dose we don't know. It will depend on the size of bleb.
Actually, it has not been described as yet, I guess, to the best of my knowledge.
People are assuming that maybe 100 microgram is the upper limit. It's all kind of nothing is there, right?
And one question from Dr. Rakesh Juneja that is directed towards Subhendu sir. So he has asked you to kindly elaborate the detailed composition of the cocktail anti-VEGF plus TPA and air, and maximum how much can be injected.
Like 20 milligram of TPA powder, I'm dissolving with the 20 ml of BSS fluid, and from there I'm using 0.05 ml. That is the TPA part, and the anti-VEGF injection usual dose, and the air is 0.03 ml. So this is the but you have to be very careful regarding the amount of blob you are forming. So if it should be spread, and actually it should decrease the subfoveal subfoveal pressure. So that is the main thing to prevent the IRTG, because a lot of volume you are injecting. The cocktail, I am not doing it in a single go, but I'm usually injecting the subretinal TPA first, waiting for some time, then followed by injecting the subretinal anti-VEGF, and yeah.
Perfect. Thank you so much, sir. Dr. Avnish, maybe we can move on to the next presentation.
Dr. Subhendu sir, if we can restart your autographed presentation, and we'll take.
Can you see my screen?
Yeah.
So the autologous neurosyngenetic graft surgery was actually first described by Dr. Grewal and Mahmood, and involves the harvesting an autologous neurosyngenetic and free flap and positioning it over the full thickness macro, and they named it as the autologous neurosyngenetic and free flap transplantation. They have done so far. They did 2 to 3 publications. Dr. Barbara Padolini, autologous retinal transplant for refractory macular holes, multi-center international collaborative study group. They published in last year. Actually, they choose the area. I have seen many videos of that is autologous neurosyngenetic graft transplantation, but they described the harvesting area of in prior to the infratemporal arcade, and because it has the several advantages. Basically, that area inferior to the infratemporal arcade is close proximity to the arcade, which will assure the glove will be need to move only for the short distance to the hole, as well as the scotoma resulting from the harvest site will be located superiorly in the visual field hidden by the patient's lip. And another thing they did, they used PFO. They used a PFO tamponade for 1 or 2 weeks to prevent the graft dislocation, because I've seen a few studies done on autologous free graft transplantation. That is, the graft displacement is the major issue. So they use short-term PFO. They fill the whole vitreous cavity with the PFO and kept it for 1 or 2 weeks, and basically they maintain the supine position for 2 hours after the surgery, followed by no positioning. So after 1 or 2 weeks, they removed the PFO and they injected a silicone oil. And after 3 to 4 months, they removed the silicone oil, and the silicone oil it has been like exchanged with this SF6 gas, and patient there is both functional and recovery, and as well as the anatomical success was there. So it may achieve the use of the PFO 2-stage surgery. It may achieve for the better functional outcome. Now, now coming to the probable hypothesis of placing the graft over the free flap over the macro hole area. This is the neurosynthetic retinopathy to serve as a scaffold. And secondly, it can seclude the communication between the vitreous and subretinal space and forms a macular plug to seal the macular hole, allowing the subretinal fluid to be gradually removed by the retinal pigment RP pump. So current indications, they are the large refractory macular holes, primary very large size macular holes, and macular holes in case of macular telangiectasia, where you can see the tapering ends of the whole edges. It may not approach. So maybe it is so large. So it, maybe island flap is not, they're not, maybe it's not sufficient, and maybe the functional outcome will be because a lot of retinal atrophies is there. So they place the whole graft over the macular hole, and restoration of the inner retinal layers made better connection with the remnant of the outer retina at the edges of the hole, and thus possibly allowed better eccentric connection. So, like in this case of macular hole, it was a very surprising case for me. Like I was preoperatively hole formation. There was a vitreofoveal traction, and after 3 weeks, there was complete closure of macular hole. You can see it here. And after 6 weeks, patient came with the retinal detachment with reopening of the macular hole. So so this is the video. I thought there is reopening of the macular hole, but when I went inside, I have seen macular hole is actually closed, and there is paramacular another hole. So I stained the whole retina with the BBG, followed by tap and blow dye to get any kind of ERM, or I have to remove should I remove the ILM also? But because no ILM was present, and the paramacular hole was quite away from the closed macular. So I just gentle cautery and did the nasal retinotomy also, and trying to aspirate the subretinal fluid, just see what happens. It was very interesting because every surgeon should know what is how to do the autologous free graft for a weird surgeon. Should mandatory. See, the retina, the macular area is getting taut, and the whole side it is gradually enlarged. Just see, and just see there is sudden migration of air inside the macular. That means the posterior pole there is still tautness, and just see the whole sides as enlarged. And I made the infusion on again. There's a big defect in the macular area. So I was thinking, what should I do? I tried to inject the PFCL, and I've seen that it is going almost subretinally, so I removed it gently, quickly also. So what should I do? So I seen the air has gone to the temporal periphery. Maybe some kind of traction in the is there in the temporal periphery. So I did cauterize the panning for the dividal retinectomy there. I did retinectomy in the temporal periphery, removed the subretinal layer, as well as maybe the traction was going free. So I again started doing fluid exchange without injecting PFCL again. As much of fluid should I aspirate? Now now it is creating a very big defect in the macular area. Just see the amount of defect, and without repairing this defect, I try to approach the patient on gaining anything, maybe hand movement or PLPR vision, post-operatively also, in spite of my good success. So I was thinking, what should I do? I tried to deposit the whole margin, but it was not coming in a close level. So I planned for a retinal graft here. I took the cautery under air, the whole thing under air. Basically, already time was like I was planning for the. It was just a maybe 15-20 minutes case. Now it was already 45 minutes gone. So I used one finish loop in this case, try to separate the graft after doing gentle cautery under air without using the PFCL here in this case, and try to relocate the graft over the macular area. But the whole side was quite defect was quite large. It was the graft side was smaller than the size of the macular break. So I placed it just over the macular hole, did gentle laser around the macular hole as well as the temporal margin of the graft here, because I want the anatomical success first, followed by the functional. So I did laser, injected silicone oil here, and finally the graft is already in place. It is attached, and you can see the macular graft is here. You can see the graft is here. So this is one case. This is another case where you can see there is reopening of there is macular hole with retinal detachment, recurrent RD, and as well as another infratemporal break here. So after doing vitrectomy and retinal graft placement under PFCL, in this case, the graft after 3 weeks does in situ. This is another case too. And after 6 weeks of the graft is gradually taking its shape. And after 38 weeks, it is almost you're taking there is a good take up of the graft along with the on retina, and patient's vision are finally improved. So post-operative problems, whatever I came to know from the literature, that graft displacement, although I have very limited experience in this situation, is another issue. Subretinal migration of the graft is another issue. So intraoperative use of PFO, filling the vitreous cavity from disc to behind lens or IOL, then keep it for 7 days, then go for siliconal PFO exchange after 7 days, and followed by siliconal removal along with SF6 injection. Another issue is shrinkage of the graft tissue. So these two complications are maybe the problem, maybe a lot of cases experience we have to gather to gain many other complications or to get rid of these kind of complications. Thank you.
Thank you, sir, for this couple of very interesting cases. We may have Dr. Raja, sir, if he can share his screen for his set of cases. Sir, can you just keep it to the bare minimum because we are overshooting the time, please? Raja, sir, you are not audible. Can you start your mic on, please?
Yeah, am I audible now? Yeah.
Yes, sir.
Yeah, this is a case of reed detachment. You can see there are two holes there, one in the macula and one is again in the macular area, but away from the fovea. Recurrent retinal detachment, underwent multiple surgeries before. This is a case where I've I've attempted 2 graphs to be put on the 2 holes that you can see in the macular area. Only couple of things which I want to add, things to make your life easy in this kind of cases, use valve cannulas, and that will decrease the intraocular turbulence, and you can slightly, and you can have a better experience to use valve cannulas. And this is typically a rare case I'm showing just to show the struggles that you can see in surgery of this with this graph. Yeah, yeah. Ideally, you should use a bimanual surgery while displacing this graph. It's not good to try to manipulate with a neonlery. Liberal usage of PFCL, and it should be you. And it's always good to easy to take a graft in a detached retina. So inject PFCL up to the edge of the retina from where you want to take a graft, and you place a small pedicle there, and then inject more PFCL, and then while displace the graft under the PFCL itself. I'm showing this video only to show the difficulties that one can face during this kind of surgery. So graft pedicle is made, and more PFCL is injected. Instead of having a chandelier, doing a unimanual surgery is not a great idea. You should use a bimanual this thing. And it's always good because it's a high myopic eye. You should keep in mind the curvature of the eyeball and try to pull it down rather than horizontally. In this case, I ended up slightly pulling it horizontally, and the PFCL was not completely filled in the eye. And then had the PFCL been completely filled, I think I would have had a better time. In this case, now it is partly outside the bubble, and I'm trying to use the other instrument to see that the harvested graft is put in on the macular hole somehow. Yeah. The other instrument, as Dr. Subhendu has shown, is good with what a finesse loop is a good instrument to have for manipulating the graft, I realize, as well as a flute needle with the tip outside closed is also good because that will not suck the graft badly. So once graft becomes a globule like this, becomes slightly challenging to put it. And with difficulty, I managed to put it on the hole. And ILM forceps is also not a good instrument to catch hold these grafts. End opening forceps, maxillary forceps, they are better placed because they're trying to crush this. Yeah. So end rip forceps and a finesse loop is a good instrument to manipulate these grafts. Yeah, finally struggled to manage to put it in place. Yeah, this is I wanted to show that the difficulties that you can have, you should ideally slide the graft along the curvature of the globe rather than pulling it horizontally from the periphery where it will come outside the silicon oil buffer. Yeah, I'll be doing one more graph to keep it for the other hole. But again, lands up in a similar trouble like this. I think we can take questions, Dr. Avnish. We can run this particular subject.
No,
The video can keep running.
Right.
Yeah.
So we'll start with the questions, and it is open to all the panelists here. So first, I would like to ask, where do you actually choose the donor site? Whether it is like according to your convenience, or you think about the scotoma that would be caused, and what are the chances of an RD? And also, yes, sir.
Yeah, yeah. Actually, most of the cases where we've done this graft is case of a retinal detachment. So most of the cases, the graft has been harvested from a retinal detachment. So that is basically depending on your ergonomics of the hand and the convenience, preferably superiorly, nasally or temporally. It doesn't matter. Big difference. But otherwise, if you're purely doing it in case of a macular hole, if a large macular hole, if you're doing it, then I think it's always good to do it from the nasal quadrant. Yeah. Then detached retina, I think it's all the area where the retina is already detached. You tend to take it from that place. Yeah.
Thank you, sir. So one more thing about the size of the graph where we are seeing, as Dr. Shubhendu sir told, that one of the side, like the complications
Yes.
contraction
Yeah.
of the graph. So do you prefer having a bigger size graph, and of what size?
Yes. Hello.
Yeah.
Can I tell?
Yeah.
Basically in the literature, Dr. Grewal and Dr. Mahmood, they are already described as 1.5 to 2 times larger than the whatever the whole size. If it is roughly like 1,000 micron size, so you have to take the this thing for 2 millimeter size graph. So, and the minimum size of the graph for any kind of failed macular hole, they have kept it for 0.5 mm. That is at least 0.5 mm, that is 500 micron. That should be the bare minimum size of the graph to hold it to for the easier manipulation. So 500 micron graph, at least you should maintain, and more than the 500 micron size, the whole size should be there. For the large macular hole, it will not close with the ion filling or only fluid exchange with gas. This kind of situation, you have done the already ion filling. Inverted free flap is also, it's not very cumbersome. So, and they are making it maybe two-stage surgery. It is some people are preferring two-stage surgery, but I think what Dr. Reddy was showing it, holding the graft with the forceps, it is, although in most of the studies they have described it with the forceps, but I think under the PFCL, if you use the finesse loop under the PFCL, it will be very easier procedure, and it will be very controlled manner. Like most of the procedures graft in the on retina, if you are operating on the on retina, so you are creating a small blade-like elevation just over the disc or below or above the temporal vascular arcade. So Grewal, they recommended inferior to the inferior temporal arcade. In some Chinese study, they have described it in the, and one from the Taiwan study also, they have described it in the just above the disc. So, and I have seen 2-3 videos where the graft has been taken from just above the superior vascular arcade. So people are choosing the harvesting the site of from where the graft should be harvested. This is not it is not fixed. So people are choosing some superior to arcade, some are inferior to arcade, some are maybe what Dr. Reddy was telling, it is nasal to the. So I think according to your convenient position from where you can manipulate the graft to the macular hole, but it should be close to the arcade, close to the macular hole. If you want to traverse the minimum distance from the harvesting site to the macular hole. Another thing, in case of retinal detachment, you can take the free graft from the break margin. So from where you are harvesting the graft is much easier, but that may be in further in the peripheral area, supratemporal and infratemporal area. So these are the things.
So I think I have one small question for Dr. Shubhendu.
Yes.
They also described tucking one of the edge under the hole, one of the side of the graft under the hole, and keeping the other one over the hole. What is your approach? You want to tuck the graft in, or you just want to place it? Because if it is,
I have very few experience. Like they are actually in fear of graft displacement, further post-operative graft displacement. They are tucking the hole. But let's see. I have very minimum experience, so I should.
I wanted to ask both of you, Dr. Shubhendu and Dr. Dipendra, as Dr. Raja sir said that taking it from the detached part, it is more easier. So what are your take on taking the graft? From which side would you rather prefer? Whether you would want to go in from the detached retina, or would you want to induce a detachment and they can take it off, or you can take it from the attached retina? Also, what I could see was sir has actually done a endocautery and has harvested the graft. So do you prefer actually doing an endo laser followed by an endocautery and taking the graft out, or you later on when you are like when we are putting in before doing an FAX, then at that period of time you'll do an endo laser onto the graft side?
If the retina is on, you have to elevate it by injecting subretinal injection, BSS. Then only you can take the graft in case of on retina. But if the retina is already detached, so there is no point of inducing retinal detachment. You can take the graft from the break margin. Another thing is, in original study by Dr. Grewal and Dr. Mahmood, they have described after doing the endocautery, so they are keeping it over there and did it endo laser also. And from the inner part of the endo laser margin, they just took the graft, holding it with the in gastric forceps, and they have just shifted the graft over the macro.
So cautery, besides hemostasis, has another role that incidence of CNVM also they say becomes less. So that's why they have promoted that cautery is also important.
Yes, they did OCT.
Another thing,
OCT.
I think I've done only 2 cases, but I keep discussing with Dr. Shubhendu and Dr. Reddy. One of the, even if you are doing it in detached retina, to drag the graft bimanually, you will anyway reattach by putting PFCL. So what I think maybe ideal is you just put enough PFCL so that your graph is partly covered and pedicle is easier to cut without PFCL. And once you have cut, then you can put more PFCL to cover the whole area. What Dr. Reddy was saying is that sometimes by reflexly you pull it up, and if you are out of PFCL, it will roll up, and then you will have
the problem starts.
Yeah.
So, sir, is it always advisable to have it under PFCL, or you can do it under BSS also, like mobilizing the graft?
Mobilizing graft under BSS is very difficult. So you have to do it under PFCL. You have to give my best of your best try you should
and
give.
Preferably, under PFCL, and also preferably in valve cannulas. Valve freshly used. I mean,
to prevent the goblets formation.
Non-valve cannulas or reused valve cannulas will cause you trouble.
So for that case, again, what are the machine settings you would want to prefer? What would be the vacuum and what would be the suction pressure and all? I mean, do you want to reduce the infusion IOP of the set of the surgery when you are actually mobilizing the graft? The infusion pressure, how much it should be, and how are you looking at it?
Your legs.
Yeah, infusion actually, I think anything that causes the intraocular turbulence should be reduced while manipulating the graft. Whether you're doing it as BSS or under PFCL, reduce the infusion pressure to less than normal IOP level 20, and then do it again. That'll be better.
Do you have any experience with viscoelastic to actually keep the graft in place? Any of the panelists, do you have it? Would that actually help in actually tamponading or keeping the graft in position somehow?
No. I've seen video of where the dye stained viscoelastic is being used. Actually, the visibility becomes an issue when you use a viscoelastic. You don't see it, so whether it is there in place or no. But typically, I have not used viscoelastic. I'm not sure if it's really going to help. The other thing that people do, as soon as you place the graft, even if you've done under BSS, so it gets possible to do under BSS. Once the graft is placed on the hole, then you immediately put a PFCL bubble over the graft. Putting a viscoelastic beneath the graft is of little or no use.
So one more question was, what about the orientation of the graft or post-operative integration? Whether it should be upside down or proximal or distal orientation, does it have an effect? If during the mobilization, if the graft kind of, how do you actually look in for the orientation of the graft onto the onto the donor side?
You have to always consider the upside down manner. Like you should respect the upside down manner. Like that should not be just upside down reverse.
Yeah.
That situation.
I think 2 reasons I agree.
Careful.
I agree with Dr. Shubhendu that 2 reasons. One is your OCT will look at least cosmetically better. And tomorrow down few years, researchers ultimately prove that it has some functional impact. So you will not repent putting it upside down. So better to put it, try your best to put it in upside down. We were discussing also that it may also be important to keep the orientation of nerve fiber layers also same, proximal versus distal. So drag it in as it is position and put it. But easier said and than done. It's challenging.
Right, sir. So any experiences with chorioretinal sort of grafting in these sort of cases? Dr. Raja, Dr. Subhendu, Dr. Dipendra, sir?
Chorioretinal graft in case of macular hole? No.
Any
No.
of the other situations where you
No. People have done the full thickness neurocystic retina RP choroid graft. It's taking the whole neurocystic retina RP choroid graft in case of submacular scar. That Dr. Badawada Paloni last time in DRF also there she has presented that for the scar, submacular scar. But nowadays they are doing the full thickness neurocystic retina RP choroid graft. So creating the hole, taking the punch of the macular area removed, and they just did the from the any healthier part, supratemporal, infratemporal part. They are taking the full thickness graft, neurocystic retina, RP plasminoid, and they're placing it over the macular area, just repairing that scarred macula.
Right. So in this, after the graft has been placed in position, do you do a PFCL oil exchange, or do you do an FAX and do an oil, or do you actually put the PFCL, wait for some days, and then you do replace it with some the oil, or what sort of oil do you use? Do you use heavy oils in this?
No, normal.
No.
1300
Yeah.
1300 centistore.
Normal oil, and it's good to if you can do direct PFCL and silicone oil exchange rather than doing air PFCL and then silicone oil. There is again chance that the graft might displace. It's always good to do a direct PFCL and silicone oil exchange.
I think we'll ask Dr. Devakant if we have any questions from the audience. Dr. Devakant?
Yeah. So there are a couple of questions regarding the functional outcome of this surgery. So a lot of people want to know that. The visual outcome, does the vision improve after this?
See, most of the cases, what I've done is case of I've done 4 or 5 so far, for retinal detachment with macular hole, with a large macular hole that its other maneuvers are not possible. In that case, I think the success is there in the sense that the macular hole is closed, and I don't have those. I immediately don't have access to OCT pictures. I have OCT angio as well, with good integration of the graft, but vision improved, but we cannot say whether it is due to the graft or the paramacular area that has picked up the retinal sensitivity. So most of my cases, they have been with a retinal detachment with macular hole, where the success is to attach the retina, and it's been fair. I exactly haven't done in case of a full thickness macular hole, which is the actual proof, that how much is going to be the macular sensitivity that returns in that particular patient.
Right.
So what about the post-op positioning? Do you actually give it for a longer period of time, or do you stick to 1 week or 2 weeks max?
I think 1 week is good enough, I think, and the other elsewhere, whoever does this, they remove the whatever tamponading agent in 2 weeks time, 2-3 weeks time. 1 week should be good enough.
I think we'll sum up with this topic, and we'll go to the third topic of surgery under oil by Dr. Dipendra sir. Dr. Dipendra sir, if you can start loading your screen presentation, please.
Hello. So is it visible, my screen?
Yes, sir.
So I'll take up the last topic, surgery under silicone oil itself. A lot of you are already doing it, so I'll just walk you through different type of maneuvers which we are doing under oil. And all of us, we are surgeons. I know that use of silicone oil is credited to these two greats, Stibis and Scott. Interestingly, you go through their initial papers, and when they describe silicone oil, they didn't describe it as a tamponade. They actually described it as one of the tool to dissect membranes, and specially highlighted that visualization of membrane gets better when you do it under oil. So this was way back 1977. Now all of us are using silicone oil in our practice for all these indications, but if you ask me, most common is still complex rhegmatogenous detachments. And despite all the success we all have had, almost 10% will have a recurrent retinal detachment. And if you have to operate these cases, I think there are two options. One is to just go for the full-fledged surgery where you remove oil and then do the full surgery and inject oil. Otherwise, there is another option. You can just redo some of these surgeries under silicone oil itself. My own experience of working under oil goes back to the fellowship days when we had this multiple subretinal PFO bubbles in a patient with giant retinal tear. And those days, we were not sure whether vacuums, we didn't have advanced machines. So I was not sure whether vacuum will work under oil and will I be able to aspirate, but incidentally, I was able to do it. And since then, we are doing a lot of maneuvers under silicone oil, but practically almost everything except ILM peeling. You can aspirate subretinal fluid, you can peel the membranes, you can do laser diathermy, less frequently required, but you can still do retinectomy and vitrectomy also under oil in some circumstances where there is some residual vitreous because of some unavoidable circumstances. So why I say that you should try doing this, especially for people who have never done it, is one reason is that it becomes a very less invasive and faster surgery, and it actually creates a compartment. So all your factors which can lead to PVR, your normal retina is not exposed to that. And if you have a macula on redetachment, then avoiding SOR will, you can avoid macular redetachment. And all of you must have witnessed all your oil filled patients almost never complaining about quality of vision. So many of them have good quality vision. It's all because that silicone oil is an excellent ocular media. And when we started doing surgeries under oil, we had a concern that what about bleeding? But incidentally, we realized that bleeding, even if it happens in a very small compartment. It doesn't hamper your view. And retinopexy is better under oil. You get good burns with less laser power, and the problems related to air are also very less if you are doing it under oil. Another advantage of compartmentalization is that retina is very less mobile when you are operating under oil. So if I go to extra inventory, you don't need any extra inventory for this surgery. But just one thing we try to do is that try to use same silicone oil which was used in primary surgery. And our earlier technique was 3-port technique when we used to inject silicone oil through infusion cannula. And my assistant used to inject it, and that was little more cumbersome and messy maneuver. And rising IOP was a big concern in that technique. But off late for last 3-4 years, we realized that if 2 ports are good enough, and your injection and aspiration need not be synchronous. So now I'll just walk you through a few cases. Now, this is a typical scenario where you can use silicone oil surgery under silicone oil. Like this patient has giant retinal tear, and within 2 weeks you see a redetachment coming from seepage of SRF from inferior edge, which has opened up. Now you don't want to do a full-fledged surgery for a giant retinal tear. This is a very old video, more than 10 years. So we were fixing 20 gauge port for oil injection those days, and another chandelier. So it is practically 4-port, just to allow you bimanual and indentation yourself. You don't want an assistant to do the indentation, but you could aspirate SRF under oil, and if you see nice laser reaction coming, you know that retina has got reattached. And this is true about small gauge surgery. You can switch ports, and you can even laser the anterior most edge because visualization is very good. So this case was successfully reattached. Now this is another case, myopic redetachment with macular pucker and inferior redetachment with a subretinal band. Now if you see, I am peeling the macular pucker in under silicone oil, and one can feel it very easily. Visualization is good. There is very less turbulence. And once I started draining subretinal fluid, I realized that subretinal band is stenting. Just creating a retinal break and dissecting. This is a limited amount of retinectomy, and again you do laser and indentation. And you can see the patient did very well without extensive resurgery. Even after SOR, patient did very well. Now this was our first experience where we could test vitrectomy itself under silicone oil. So I'll just give a background that why we had to do this. This was a trauma case, foreign body, and somehow they had hepatitis also. So we repaired perforation, and then we realized that there is a detachment and vitreous hemorrhage, and foreign body is subretinal. So I'm inducing PVD, and then after putting PFO, I took out the foreign body and reattached the retina. There was a large break superior to arcade, but still, this case had to be done under local anesthesia, so we couldn't complete the whole thing. There was scarring and this residual sheet and an open break here. So we did this surgery under silicone oil itself, and as you will see, the whole vitreous which was left inferiorly and there was a hyaloid we could separate very easily under silicone oil. I could separate this hyaloid, and this is the step I wanted everyone to see, that you could do interface vitrectomy under oil, and that this is probably the new generation cutters and machines that do. The whole thing is still very controllable under silicone oil, and you see retina is mobile, and but I could remove all the blood and vitreous in this oil filled eye. And my assistant is stepwise injecting oil when I'm doing this. I'm keeping a watch. I should not. I should maintain a normal intraocular pressure. Keep watching disc and keep looking for peripheral choroidal folds. If there are some choroidal folds, then he has to inject more. If you see that disc is losing pulsation, or then you have to ask to stop him. So that was the older technique. Now this is again a very high myopic patient having a large inferior break and with detachment. So we did almost everything right to reattach, peeled ILM, lasered the large break, have put silicone oil, but he comes back after 4 weeks with redetachment and 2 star folds. And this is a very common scenario, phakic eye, young patient, silicone oil and large break, star fold opens up the break. So again, we planned a resurgery instead of doing the extensive silicone oil removal and the whole surgery again. So again, this is resurgery planned under silicone oil. And you can see the membranes can easily be peeled under oil. And whole the visualization and the medium is absolutely stable. You can see, even if I'm not using walled cannulas, but and once you have removed both star folds, internal drainage works excellent under silicone oil. You can see this video is showing it. So that was the whole aim of this surgery: relieve the traction, drain the fluid, and do laser and inject some more oil. And using chandelier allows you to, you all know that bimanual thing, you can indent yourself, so your surgery becomes more controlled. There's another break in the superior area that was also lasered. So you can see the 4 weeks patient did well, and then this is 3 months after removing silicone oil, retina nicely attached, and because second surgery was not that invasive, overall optic nerve and everything looks good. But when we started trying this in diabetic cases, I think it is little more challenging, and we were very hesitant initially that should we do it for diabetic also, because diabetic TRDs, if your primary surgery fails, the second surgery is anyway more challenging. So these are just some cases where we could do it successfully, but I'll still say that be very careful. They should not be your first cases, uh, because many times they need much more dissections. So this patient was having inferior redetachment with sub-silicon oil membranes, and I'm doing bimanual surgery. I think the later part of video you will see little better. And that was the challenge when we were injecting oil through infusion cannula. This cannula will keep coming out. So that is why now we don't use this technique. We keep injecting oil from the main port only, just like we do our routine silicone oil injection. And you do it intermittently. You don't have to do it constantly. Just refill the cavity with silicone oil so that pressure is well maintained. And again, whatever peripheral attached vitreous is there, you can cut it. You can do bimanual and dissect like you do for your primary diabetic surgeries. Uh, Again, and then you do the fluid air exchange and do good PRP in these cases. Another case I just wanted to show that you can also do a limited retinectomy also under oil. Again, this patient had this inferior contracted retina, PDRI, and this retinectomy has been done, and then you indent and do good PRP. This was even a more challenging case because pupil wouldn't dilate and he had only one eye. He came very late. We did a primary surgery for very complex TRD. We could reattach macula and temporal and superior retina, but nasally again it got contracted, active vascular fronts. Now, my challenge was if I do silicone oil removal, I think I'll not be able to complete the second surgery because whole thing, macula will also redetach. So we just planned a resurgery under oil. Idea behind showing this video is that you can do extensive retinectomy also under oil. Although again, the same thing that maybe functional recovery may not be great, but anatomically you can still reattach these eyes. The concept is same. You have to relieve the whole traction before attempting fluid air, this internal drainage. Otherwise, oil will try to go subretinal in these cases. If I have to sum up, what are the ideal cases where you can choose this technique? One is that eyes which require limited interventions, like you have a redetachment due to open break or new break or missed break. You have just one or two star folds. Another thing, if you are dealing with a recently operated eye, this is again important because if your oil has been in eye for more than 3-4 months, then chances of emulsifications go higher. So you will tend to exchange the oil rather than retaining the same oil. And especially the younger patients with phakic eyes, I think if you do a silicone oil removal, again do a resurgery and inject, chances of getting cataract, and sometimes if you have a deficient posterior capsule, then also you should avoid a surgery under silicone oil, but in phakic eyes it is preferred. And I have shown that non-vascular cases are ideal candidates. Like if you have reg RD which is recurring, probably under oil, they are better repaired. Few more learnings, the modifications which we have done recently is, again I have highlighted that just 2 ports are good enough. Unless you are planning to do bimanual, then you can make third port for chandelier. Otherwise, you keep injecting from your right side upper port and then keep aspirating from that port only. Try to make your ports opposite to the site of pathologies because you need to visualize that thing if you are planning to put chandelier. And last thing which we have is very important is try to keep IOP at the lower side when you are concluding. And in general, resurgeries under oil, I tend to suture the ports even if they are 25 gauge because they tend to leak. So you don't want subconjunctival oil. You also don't want underfill. There are few limitations. You can't do all your resurgeries under oil, especially when you are planning to use PFO. You can't use it. There is a risk that if there is excessive bleeding, it can get in the premacular area, and then you will have to go for extensive surgery. Yes, there are increased chances of oil emulsification, but in general, if you are operating early, then chances are not higher than what you see in primary surgery. So to conclude, it's a good technique in our armamentarium, and use 2 ports technique. It's minimally invasive, and practically we can do all the maneuvers under silicone oil itself. So that concludes my talk. Thank you.
Thank you, Dr. Dipendra sir. We would like to ask Dr. Bhavik Panchal if he can start sharing his screen. Dr. Bhavik is a consultant at LVPI Vizag. He did his VR fellowship at LVPI Vizag itself under Dr. Avinash Patangya. Dr. Bhavik, if you can please share your screen, please. Thank you.
Yeah, so hi Avnish, and hello everyone, and thank you Dr. Dipankar for the wonderful presentation, sir. And can you see my screen?
Yes, Dr. Bhavik, please.
Yeah. So I'm not going to take much time because sir has already covered very nicely the different uses of the two-port uh, interface vitrectomy. So just want to share a case about a 41-year-old male who came to us post-trauma. It was an open globe injury, and on presentation he had vitreous hemorrhage, retinal detachment, and also presence of an intraocular foreign body. So there was no endophthalmitis. The visual acuity was PLPR accurate, and we can note the retinal detachment here with my arrow is visible. And he had an intraocular foreign body in the inferior retina as well. So we operated him. There was a traumatic cataract as well, so removed the lens, put an acerclage band. So this was the site of impact of the foreign body where there's a break, and this is a drainage retinotomy, and this is under oil. So the visual acuity improved to 21-25 after post of 3 weeks. So as expected, because of the site of impact very close to the posterior pole near the inferior arcade, the patient may develop PVR, and that is what happened. So 2 months later, patient was vision dropped 2600. We can see a epiretinal membrane basically going and dragging the fovea and towards the site of impact. So if we trace the vessel here and the macula here, we can see further that this entire system or entire superior arcade is dragged towards the inferior arcade or the site of impact. So I'm just going to show a about interface vitrectomy, where a two-port system was used. This is a Lander's contact lens, basically macular lens, where you can see I'm skipping the basic steps here to keep the video short. Membrane peeling under oil, where membrane is identified and separated from this. The oil peeling is little difficult under the oil, but as you can see here, the membrane is separated from the superior arcade, and as you go further, even from the optic nerve also the membrane is separated towards the impact site of impact. So care was taken here that only the membranes are separated towards the impact site and not to create a break here. So this patient had an inferior traction. Because of the traction, inferior retinal fold with some fluid which was present, but there was no break which was present on this for this patient. So going into the wide angle lens now. So once the membranes were separated from the macula, rest of the membranes were dissected using a wide angle. So as you can see here, the rest of the membranes are separated from the optic nerve head towards the site of impact. And as Dr. Dipendra mentioned about vitrectomy as well, so the rest of the membranes from the site of the impact were removed using the cutter. This is one of the cases where just a membrane peeling was done. This is the post of day 1, where you can see the macula is separated, there's no traction, and the of impact is free from the impact site. The small membrane of the disc was left, however, it was cut from the main impact site here, and this is the pre and the post photograph. This is just a post of day 1 photograph, as this was operated just 2 weeks prior. The patient will be visiting us further, and even just a post of day 1 itself, the visual acuity had improved to 21-25. And we kept the oil inside as the retinal fold was there, and I have just done 2 surgeries. One was a membrane removal and another was a retinectomy. So I was skeptical about removing the oil at this point in time. So this is what I wanted to present on interface vitrectomy. Rest of the thing Dr. Dipendra has very well covered. So Avnish, this is from my side.
Thank you. So Bhavik, thank you, Dr. Dipendra and Dr. Bhavik. Interesting sort of cases for under oil surgeries. So coming to Q&As for this session, most of these surgeries, what we are doing is we kind of see a macular pucker or a membrane developing. So how different or how difficult it is to do it under oil, or is it the same as what we do it routinely? Dr. Dipendra sir, if you can answer.
Yeah, I think yes, that's a good question. First time when you attempt, you are also anticipating that there will be some difference. But see, when you try to approach the membrane, sometimes these reflexes can give you a trouble. But on the other hand, oil itself makes the edges more prominent because there is some shadowing effect. And uh, another thing is that you don't have any other turbulence in the media unless your IOP is not well maintained. So I would again like to highlight that what happens is if you are operating under oil and you lose some oil, there is slightest hypotony, you will get corneal folds and other things. So if your IOP is very well maintained, not very high and not very low, then I think peeling is as good as under fluid. All your movements and all are exactly same. You try to follow the same steps as you do under fluid, so you don't need to modify it much. And of course your whole idea of peeling ERMs is do minimum to achieve maximum. So it's not that you want to get rid of whole membrane. You see the macular parts and which is the most detrimental to macular function, and you try to release that part, hold from the thickest part. And uh, initial separation has to be very gentle till you have judged the strength of the attachment of ERM to retina. That's very important. Initially you never be in hurry, you take as much time as possible. Same I think concept which you follow under fluid. Maybe I think Dr. Reddy and Shubhendu.
I just yeah, only one point. If there is only macular pucker when there is no retinal detachment, you can as well handle it to the time of siliconol removal. I mean, these are measures. The working under siliconol is only if there is a concurrent retinal detachment either in the periphery or extending up to the equator. I just wanted to say that. I mean, if it's pure macular pucker with periphery all fine, you might as well do it at the time of siliconol removal.
Yeah, so here it was, if you can see, this is the fold here, retinal fold with minimal SRF, which was this. So I was not sure. And this was just, the oil was not emulsified. And to be honest, this was case which started in the late evening. And I didn't want to waste the oil. So this, as Dr. Raja has already presented one of the other earlier forums with we both were part of that presentation. It is actually a very, like Dr. Dipendra also mentioned, it just takes 10 minutes. Make two ports, go inside, remove the membrane, come out. It's a straightforward surgery. And choice important is the selection of case. So yeah, you're muted, Dr. Dipin.
Yeah, absolutely. I think another thing is, see, I'll not say that fellows before even learning the routine vitreous start doing it, but during our training, we used to be very hesitant to do any intervention under oil. Like oil used to be the concluding step for VR, and then you say bye bye and till you remove the oil. But this is a very important point that if suppose you have removed a foreign body and you find another one, somehow you missed it pre-operatively or something, you can again do similar maneuvers to retrieve another foreign body without doing an SOR. So, but yes, of course, Reddy said rightly that if SOR silicone oil is likely to happen in few months or few weeks, then naturally you will schedule the membrane peeling along with SOR only.
True. Yes.
Yeah. Dr. Bhavik, I think you can stop the screen. We can all can view the screen share.
Yeah, sure. Yes.
So one more thing which we commonly encounter, over a time we sometimes tend to see the oil going subretinally. So how difference does it make if you're doing surgeries under oil in these kind of scenarios? So how would you proceed with oil under the retina in these conditions? Sorry, Dr. Dipendra sir.
I think I like to know Dr. Reddy and Dr. Shubhendu's opinion. I have answered this question in some other forum already. So
Basically, if your oil is going subretinally, that means some kind of traction is there. Anytime you have the option to convert it, to remove the oil carefully, whole oil, and then do the surgery, settle the retina, and inject the oil again. So that option is always with you. But until and unless the oil is not going subretinally, you can always tackle this type of cases early PVR, not much of fixed volt, not much of ARM, not much of like traction, and anytime you can convert your surgery to the like removal of oil, doing the settling retina again, and you have that option. You have that.
Dr. Raja sir, your comments, please.
Yeah, I haven't operated, I haven't done in cases of with subretinal silicone oil, but I mean, whenever there is a subretinal silicone oil, that means that patient, that particular eye requires a relaxing retinectomy. You can straight away do a relaxing retinectomy, and then whatever subretinal oil is there, that should come into the vitreous cavity and get mixed up. I mean, Dr. Dipender.
Just to add, I think I fully agree with both of them that see behavior of taut retina under oil and air is absolutely same. So the moment you realize that air or oil is going subretinal, you realize that there is some residual traction. So either you peel or you cut. Same philosophy applies under oil. If you have already done some retinectomy and still you see silicone oil going subretinal, then your retinal reattachment experiment is failing. That's what I think Dr. Steve Charles called that whenever you do internal drainage, fluid air exchange or fluid oil exchange, if your retina is not reattaching, your experiment is failing and there is some residual traction. So again, good part is you can do retinectomy and even peeling under oil also. Air may not give you some extra advantage. It's only that we have been used to do more of retinectomies and peelings under air. So that's why we think that we have to remove oil and then probably we'll do it better. But as you keep on doing it, you will realize that same maneuvers are as easy in under oil as as easy or difficult they are under air.
Thank you, sir. Do you have any experiences of instead of using an oil or a gas with the like during the procedure, instead of using a gas oil, you're using a gas? So do you have any experience with that where under oil and then you have injected instead of the oil, you're putting a gas on and you're doing the surgery?
Okay.
Dr. Raja sir, Dr. Shubhendu sir?
I don't know. I think when we are injecting under the air, the whole idea is that you want to retain the silicone oil as the tamponade. We do not. That is the whole. That's why we do not want to change the tamponade with any other thing. I mean, when we're working under oil, we do not want to put gas. I didn't exactly get the question.
Instead of like normally we in these sort of scenarios we keep on injecting oil, so just to maintain the intraocular tension, instead of using the oil, can we use a gas? And do you have
I think gas will hamper the visibility, the interface between oil and gas. So all the fun of working under oil is lost if you put gas instead of oil. I think it does not make it. It's better to keep injecting oil and not gas, because gas again sometimes inadvertently some small oil bubbles do enter the vitreous cavity while injecting silicone oil. They actually hamper the view, and it's not a.
May I have a comment, please?
Yeah.
Basically, for the gas and air has the like highest interfacial surface tension, so against the water. So, doing the resurgery under gas or gas, whether it is gas or any kind of like gas, like simplest gas is the air. So under air or gas, it is very difficult. But you have to use it under PFCL and under oil. Basically, oil or silicone oil or the PFCL has the lesser surface tension than the gas or air. So under oil or PFCL, it will be much easier for doing the maneuver, ARM removal or relaxing retinectomy or eating up some peeling the membrane. It's much more easier rather than using it under gas or air. So because of their high surface tension. So under gas, I won't prefer it won't work also, I think so. It may work, you can do with vitrectomy also, but doing the other maneuvers, removing the ARM or because
I think the series which I have described that to maintain you can but I agree that see like the whole dynamic is quite static. Oil doesn't leak out that fast, especially with 25G ports. So it gives you a lot of time. You need a refill after good 5-10 minutes. So that's the beauty about this. The smaller jogging is less. And if your initial oil was like 5,000, you have to do very less of refilling. And we don't want an dynamic fluid dynamics happening, rather a static thing like PFCL. Why it's better? Because it stabilizes the thing, so very less turbulence. Fluid creates turbulence, and gas visualization is not that great. That is again a challenge. And the advantage of having gas, doing retinectomies under gas is maybe you can get better hemostasis by raising the pressure. With oil, I think sometimes you're not able to achieve that. So that is the only advantage. So, but I think very good question.
Right.
Yes. Can you show one of my video? Sharing my screen. That interface video, what Dr. Dipender has already explained everything, and not much of PVR. That this is one of my case where you can see the preoperative, there was a hand movement close to face and there was huge choroidals. So I did vitrectomy, PFCL injection, choroidal drainage, FG, EL, silicone oil, and patient after 3 weeks, patient presented to have improved from hand movement to finger counting only because of recurrence of retinal detachment. You can see the open break. A lot of peripheral inferior traction is there, reopening of the break is there. So I choose for the approach, one for the light pipe, another of the peripheral traction, and ERM removal. You can see, and remove all the traction from the periphery. Basically, the previous changes in the up to mid periphery, it was not that much. While you can see the movement of retina, it is like you can jolly well do the all kinds of maneuver what Dr. Dipender was telling, and just see the removal of BRM was so easy, and there was the open break. That was the site of open break. So I remove all kind of traction, peripheral traction. And finally, I the kind of traction, and the brake was there, and I just cauterized it, and I kept another foot to inject the silicone oil in this case. And now injecting the silicone oil, and you can see the silicone oil flow is coming and aspirating the fluid with the help of cutter, SRF. And after doing complete drainage of the internal drainage of the subretinal fluid under the oil, you just do the laser, and retina is absolutely flat now. You can do laser here. Use and do some kind of laser and the inferior periphery also. Maybe you may miss some break. So I did laser here. So I finished up this. And postoperatively, after removal of the silicone oil as well as removal of the ERM, finally patient gained 6/24 vision. Thank you.
Thank you so much, sir, for this interesting case again. One last question, I think, Dr. I think we have one question by Dr. Hemlata. She is asking, is it safe to do subretinal surgeries under oil? And what sort of cases do we can do under oil subretinal cases?
Yes, I think again, question is, if there is no traction, the purpose of your surgery is like just to maybe manipulate a graft in a oil-filled eye. I think, and put it subretinal. I can assume that kind of maneuver can be done, that you have done a graft and it has dislodged, and then next you see it 2-3 days later, and now you don't want to do SOR and lose that graft also. You can see the graft, so you can do a resurgery and maybe just push it subretinally. But otherwise, most subretinal surgeries are quite extensive. You have to induce redetachment, create a large flap, and then go subretinal and remove the CNVM or scar. So I don't think it will be, I think PFO would be a better medium to do it rather than oil. I think Dr. Shubhendu is much more experienced. He can tell.
Yes, it is. It is better to remove the oil first, then use the PF seal to stabilize the pole and do the subretinal surgery. If necessary, then you have to reattach the retina using the PF seal.
Thank you so much, sir. I think it's 9. So I think we'll conclude it. I would like to thank all the panelists, Dr. Shubhendu sir, Dr. Raja sir, and Dr. Dipendra sir, and also the presenters, Dr. Ashish and Dr. Bhavik, for giving us their extensive cases where we had actually learned a lot of different tips, and great learning for everyone who has attended the session. We would be back again with some more interesting cases and topics. Till then, thank you so much. Thank you so much.
Thank you.
Thank you, everyone.
Thank you, Avnish and Devakant, for moderating it so well. We apologize for not being able to live stream this time because of some technical glitches, but I think we'll try to improvise next time. Thank you. Thank you, everyone.
Thank you.
And good night. Stay safe.
Good night. Same to you.
Thank you. Thank you so much.